Well, good morning and good afternoon, everybody. This is Florent St. Clair with Dicom Systems. I am absolutely thrilled to be joined by my co-panelists, Mr. Richie Pfeiffer from Life Image and Bruce Hoyle from Southern California Permanente Medical Group, also known as Kaiser Permanente, Southern California. We will wait to actually start our presentation for a couple of minutes to give everyone a chance to download the Zoom app if they haven't done so yet. And then at 11:02, we'll get our presentation started. In the meantime, if everyone will be muted. And so if you're encountering any kind of a tech issue, please use the chat box to let our administrator know. And for questions, please submit them to the Q&A box that you'll see at the bottom of your screen. And so we will have an opportunity for Q&A towards the end of our presentation, and we very much look forward to everyone's participation. So let's wait another minute or so, and then we will get started. I'm going to go on mute for just a minute. For those of us who have just joined us in the past few seconds, we are still on mute until 11:02 or so to give more of our participants more time for their participants to join us. So please bear with us, and in about a minute we'll start the presentation. Okay, I think we should probably get started. We have a pretty good portion of our participants that have joined us, and we very much look forward to this session with all of you. So again, my name is Florent St. Clair. I'm the Executive Vice President for Dicom Systems, and I am joined by my two co-panelists, Bruce Hoyle and...
Hello.
Hi, Bruce. And it's Mr. Richie Pfeiffer joining us from the beautiful state of Indiana.
Hello, guys.
I understand they are experiencing subtropical temperatures right now, right?
Subtropical, to put it mildly. I think last time I checked, it was -9 still.
Wow. Well, good luck. It's going to be tough for a lot of our audience on the East Coast and in the north part of the country. And so we're very grateful that you're making the time to join us today. So this partnership is very exciting to our organizations for many different reasons. The two companies, Life Image and Dicom Systems, have been around for about 11 years. So we're pretty much the same age organizations. And we've gone through a lot of transformation over the years. And in great part because of the participation of our customers, not the least of which would be Southern California Permanente Group, in improving our products. And so, next slide, please. The intent of this partnership is actually very simple. As most of you know, if you use image sharing today or any kind of enterprise imaging environment, which I'm hoping you are, or you're in the wrong webinar, then you know how much fragmentation there is among vendors. There's a huge disparity in some cases in the level of interoperability that your enterprise imaging vendors let you have, right? There's a bit of a tendency to, you know, have an attitude that is me. You know, let's keep the customer within our own enterprise imaging environment without the ability to affordably share information outside of that realm. And so the intent in this webinar is for us to, you know, portray what our vision is for this industry. And I believe we're joined among our participants by one of our illustrious colleagues, Mr. David Brown, also from Southern California, Kaiser Permanente. I'm hoping David can hear us, and we'll also enter some questions in our Q&A box. But the reason I mentioned David is very specific. 10 years ago, actually pretty close to 11 years ago, when we first launched a lot of the image sharing, you know, cloud-based image sharing industry, I can't believe it's already 10 years old. I was a panelist with the founder of Life Image at the time, and we had David as one of the participants, or actually one of the people in our audience, and he asked us a very fundamental question, like only David knows how. He said, why don't you image sharing vendors function more like the cell phone companies, right? And it's true. If I have an AT&T phone and I want to call a Verizon customer, I don't need to first make sure that there is interoperability between the two phone vendors, right? I can just dial the number and I'm now on the phone with a Sprint or a Verizon customer without having to do any kind of interoperability work to do so. Why doesn't image sharing work that way? It's very simple, right? It's market forces. You know, vendors tend to be a little bit selfish, and making it easy to interoperate with other vendors means relinquishing a little bit of the power, which is not necessarily good for their bottom line at times. And so our vision for this industry is to take this split vision of enterprise imaging, right, with above the line image sharing and below the line enterprise imaging, and turn it into a really elegant framework where image sharing and enterprise imaging are one and the same, right? It's almost like saying there's a distinction between teleradiology and radiology. Well, is there really much of a difference? But the reality is that the environment that we live in right now does not make it easy for you, the enterprise imaging professionals, to share images. There's a lot of manual labor. Richie, do you have any thoughts on this?
Yeah, so I appreciate you kind of capturing that, because I think it's really critical to our providers, especially when we know the demand that's being placed on clinicians and providers at all times, especially when it comes to turnaround. So when I look at how we work together, and I apologize ahead of time, my voice is kind of in and out, guys, because due to a cold, so I'm sorry. But when I look at how we work together and the possibilities of our interoperability platforms, you know, they enable each other. And what happens is it makes sense that we combine can systematically advance the extrinsic workflows from image sharing and the intrinsic data flows, which providers and Dicom systems can perform, and those combined can accelerate for better timing of the medical information to deliver to the appropriate care specialist and ultimately create faster turnaround times for the providers and the patients. So as we kind of go on through this webinar, you'll see examples of that, real life examples that demonstrate that.
So Richie, you have the floor.
So this a little bit about Life Image, especially for those that may not be familiar. And once again, I just want to I appreciate being on this webinar with Florent and Bruce, because they're both great members of this industry that really kind of move us all forward. So, you know, back to the slide, when I look at this, you know, what we've done is we were the company that started the medical exchange business 11 years ago, actually 11 years ago this month. And it all began because we were trying to get medical images and reports that were on a CD from a referral provider into the PAC system of an academic medical center, those centers like UCSF, UCLA, MD Anderson, right? And then over time, though, we developed a digital technology that allowed our network to grow initially across just the US, but then globally, right? And, you know, we were able to eliminate the use or even the need of hard copy media so we could allow for transfer of those medical images and those associated reports over our cloud network. And that dramatically improved the speed and the efficiency for the benefit of those patients and providers. Customers like Kaiser Permanente utilize this capability, and Bruce will go over this later in the webinar. We currently connect over 150,000 providers, and that is across 1,500 hospitals with 8,000 affiliated sites to those hospitals. In addition to the medical images and reports, we can also transport all file types. Those file types could be lab results, EEGs, genomic data, phenotypes, all kinds of information, right? And this is critical to our company because we serve all providers, meaning we serve all ologies, and that's across the entire healthcare continuum. So over this past year, we've exchanged over 10 million clinical encounters per month. That's significant. And in addition to, we are also the only exchange network actually work with the federal government, and that's due to our security standards today. Next slide, please. So this is just a snapshot of our US sites, and these are those hospitals and those affiliated networks within our network. Included in this are 8 of the top 10 hospitals across the US. And this footprint of sites is growing by the day, literally. You can ask my support team. And that data is also growing all the time. We're able to sustain being the largest exchange network in the country, and that's because we have a standards-based technology built in through our entire platform. So it makes it significantly easier for providers to connect into the Life Image network and share information as needed. Next slide, please. So the value of our exchange network and our overall interoperability suite is due to improved operational efficiencies and economical benefits. But most importantly, we're improving patient care because of the advanced network capabilities. It's better, faster, and simple. And we've heard this from customers like Stony Brook, Loyola, Houston Methodist, just to name a few. Since we enable providers to digitally exchange, we eliminate the need for patients going through the tedious efforts of getting those CDs from providers and then taking them to other advanced care centers or other providers, right, that are outside of the networks that they get them from. We also free up the receiving facilities from the myriad of instances when CDs or the proprietary applications that are associated with those CDs fail to work, and that causes delays. Means the patient may have to reach back out to an institution, the provider may have to reach out to the institution, but ultimately there's a delay and it clogs the system, right? Next slide, please. So I'm going to walk us through a brief overview of our Life Image Interoperability Suite as a whole in our topology. So on the left, those are the larger academic medical centers and advanced care centers that receive a lot of outside medical data from the referral sites, which are shown on the right-hand side. Both have different Life Image components of the Interoperability Suite, but they easily exchange medical data bidirectionally. And that's to help ensure longitudinal patient records for that patient is with the providers and it's intact and it's available at all locations, right? So we offer also for those clinicians a direct integration to the EHRs. We know that it improves clinician interaction with outside images and other medical information about the patient because it brings it into their main UI. And the most common integrations that we have at Life Image are with Cerner and Epic. If you look at the lower right-hand corner, we have something that's called Clinical Connector. And that allows our customers to send images and reports directly to patients so that they have a digital copy for when needed. That eliminates, again, the need for a CD or for that patient to have some sort of hard copy media. If you look at the top, within our network capabilities, we also have ad hoc sharing functionality. This allows our customers to send directly to a physician in a one-time manner. If they need one instance of one set of images or multiple images for one patient, they can send a link, and that physician can then open up that link and view the images. And because we have an enterprise viewer and diagnostic viewer available, that's available for that physician for that instance. And it's also available at any endpoint within our network. So we also allow users to send links in the same fashion. So if we needed to send a link to a user, to a physician or provider or a patient, we can send them a link, and that allows them to upload information as well, so that it gets back to that advanced care site. And so that's a little bit about kind of the parts and pieces. And I know I went through that a little bit quick, but I wanted to give an overview, and I also want to make sure that we have plenty of time for Florent and for Bruce to kind of go through their pieces, especially Bruce, because he's going to show some real world pieces. One of the things, though, that we've recently done is we've partnered with a couple companies. We've partnered with a company called Mendel AI, and that's so that we can help our customers and new customers kind of work within the clinical trial space, and it helps for the research and defining and reviewing those that fit the right research research criteria. The most recent partnership, though, and the one we're really excited about, is the one with Dicom Systems. We are hoping that we can provide their customers with the opportunity to use the Life Image Network with other Dicom System sites, and also to exchange with Life Image providers. And it's extremely important that I highlight that we have partnered with Dicom Systems, because they are an expert in interoperability and workflows within the institutions. And we are complementary technologies that work together for the benefit of our customers. So later on in the webinar, you're going to see real live use cases from Bruce. So right now, I'm going to turn it back over to Florent and have him discuss more about Dicom Systems.
Thank you so much, Richie. So briefly about Dicom Systems, because I do want to get to the use cases that Bruce has on deck for us. So Dicom Systems has been around for about 11 years. Actually, this month, February 2008, is when the company was incorporated in the state of California. And we've grown quite a bit, as you can see, in terms of our numbers. On an annual basis, we power about a little bit closer to 12 million annual teleradiology reads. That's across our Telerad customers. And so we were pretty much born in the external or extramural workflow world. And then pretty quickly, our interoperability suite enabled us to grow within the enterprise. So to power a lot of those intramural workflows that are so vital to enterprise imaging environments. On an annual basis, we handle about 8 billion images flowing through our servers across the board. And most recently, about 2 years ago, we started getting involved increasingly in machine learning. We have a pretty close partnership with Google. We're also available in AWS, and we're doing more and more projects involving massive amounts of imaging data that need to be de-identified scientifically to feed into deep learning algorithms. And so we've gotten pretty good at that new sport, right? Essentially an evolved version of basic tag morphing, but you can't just nilly-willy de-identify all the images and still hope that they're usable by the algorithm. So we go through a very painstaking process with each of our clients to essentially fit the de-identification process to their specific needs. And then in terms of archiving, some of our customers are using us as an archive. The US Army Dental Command, for example, in San Antonio, Texas, had us migrate 27 million historic dental exams from their proprietary archive into our VNA in San Antonio, Texas, on-prem. And then on a daily basis, every 24 hours, the VNA gets hit with an additional 5,000 new exams. So we are no strangers to high volume workflows. And what that defines for us is essentially being the plumbers of the industry, right? We are the IT people in the background that ensure that those workflows are always flowing. Kaiser, we're very proud that they rely on us for a multitude of their internal workflows. Stanford Healthcare, among other large academic medical centers, use us for virtually everything, from HL7 routing to Dicom modality worklist to actually serving as an archive for their functional MRIs. Cleveland Clinic, we're also very proud to work with them on machine learning projects as well as teleradiology projects. Next slide, please. So you can think of the Dicom Systems platform when coupled with the Life Image platform as this very effective Swiss Army knife, right? There's a lot of different things you can do with the same tools. And so you can see on the left side of your screen how our workflow engine can connect to the Life Image network over the cloud and provide both intramural and extramural workflows interchangeably. And so that means a lot more flexibility and pretty much untethered access to this huge network that Life Image offers to their own customers. And so these 1,500 hospitals and 8,000 associated sites that are all part of the Life Image network, suddenly you plug that into the Dicom Systems framework and you have a much larger network and network effect than if you had two completely separate worlds. And that is the intent of this specific partnership between our two companies. Our interoperability suite is also at the heart of everything we do. You can use us as an archive, although the vast majority of our customers today, these 8 billion images flowing through us, are transient data, not necessarily ending up in our VNA. So many of our customers are using us for moving data, massive amounts of data from point A to point B securely. Then you can deploy us in a cloud environment. You can deploy us on-prem. Really, we don't restrict you as to what kind of IT environment you want to use to deploy our technology. Now, we're a very simple Linux-based appliance that fits within virtually any IT environment. And then increasingly, you can rely on our tool sets to participate and use us as an on-ramp to the AI world, which has become essentially unavoidable for the past couple of years. The noise level in AI at RSNA and HIMSS most likely are becoming deafening. And so we're hoping to dispel some myths as well. And please, for those of us who were not at the beginning of this webinar, please submit your questions via the Q&A so that we can answer as many of them as possible live at the end of this presentation. Any questions that we didn't get to, we would be happy to have a separate conversation or email you later, but it would be best if we can discuss them live here. Next slide, please. So I'd like to introduce Bruce Hoyle. Bruce, thank you so much for joining us. Bruce is a 35-year veteran of the industry at Southern California Permanente Group, and we're very thrilled that he was able to make the time to join us. So take it away, Bruce.
Well, great. Thank you so much. First, I want to thank Life Image and Dicom Systems for putting together this webinar, and I do appreciate being invited, and I'm hoping I can add to this discussion. As this slide points out, I work for the Southern California region of Kaiser Permanente. Specifically, I work for the physicians group as their principal imaging solutions architect. For those of you that know Kaiser, our regions are quite large. We have 15 medical centers here in Southern California. And of the 221 other medical offices, approximately 120 of those produce medical images. We have been working with Life Image and Dicom Systems for several years now. And in both cases, we started by using only a subset of those systems' capabilities. But as we continue, to use additional functionality as our requirements change. We are lucky that both companies work with us, and as I'm sure they do with all their customers, to make sure that their future products will meet our needs. On the next few slides, I'm going to go over some simple workflows that show how we use these two products together to meet our business needs. I chose these specific examples not because they are all that we do with these products, but they happen to be examples where we're using both products together. And as you might expect for this sort of a demonstration, these examples are very simplified and the real world implementation can be much more complex. I will not spend too much time on each example, but I'm hoping that they will act as a springboard for questions and conversations. So let's go to the first use case on the next slide, please. So little background, while Kaiser Permanente's general practice is to perform imaging studies in-house, at least for the Southern California region, there are some exceptions to that. For example, on the edges of our region, we may outsource certain procedures, and we also have mobile providers that travel from hospital to hospital, like our PET-CT trucks that we contract with. In those cases where an outside provider is sending large volumes of studies to KP, we want to make that process as simple and automated as possible. The first two use cases will show some of the ways we've met that goal. A bit of background on this particular use case. Well, all KP facilities are connected to the same network. We do have the need for local PACS or cache servers. This is just the reality of DICOM studies are quite large, so we like to have those bytes as close to the reading physicians as possible. We also have applications that are specific to some modalities like cath that have their own cache servers. So when an outside provider sends a study to Kaiser, we don't feel it's fair to ask that sending facility to pick from a large number of possible destinations within our enterprise. You know, we don't want one destination for peds, one for cancer patients, and so on. The manual selection can often lead to a labor-intensive workflow and mistakes. To that end, we strive to have a single destination for all of our inbound traffic from a given facility. So let's look at how that might look on the next slide. So on this slide, we show the outside provider shown in the upper left here, sending to a single destination. And for this example, it's a LifeImage referral box. Studies from that referral box are downloaded to the DICOM Systems unifier in the center of the diagram there. On that, there are Lua scripts that use data in that study, as well as data that it might pull from our RIS and our PACS to determine where that study should go. We then create a number of routing rules that act upon that business logic. So let me give you an example. We have an outside provider that helps us template knees prior to replacement surgery. That vendor sends back the template in the form of a DICOM object. The original knee study may exist in our VNA, and it may exist in a number of these regional or local PACS cache servers.
Hi, Bruce.
Yeah.
Sorry to interrupt you, but I think it's important to make sure everybody in our audience knows what Lua scripting is, because that could be a little bit arcane to some people. So Lua scripting is a scripting language that's a little bit like Python. So anybody that knows how to write Python would probably be really good in Lua scripting as well. And what Lua scripting is essentially an augmentation of the GUI, right? So not every workflow can always be programmed in a GUI, right? We have a very effective GUI, of course, but it's sometimes necessary to get a little bit deeper in a workflow, and the GUI has limitations that won't allow you to do that deep work. And so the way that we leverage Lua scripting is the same way that you would add an app on your iPhone or your Android device. You essentially create a separate little app, and all of a sudden your platform, your iPhone, in this case your DICOM Systems framework, is now capable of doing something that it couldn't do before. A custom script was created to create a custom workflow that didn't exist before. And Kaiser Permanente is particularly good at that. In some cases, they write some of their own scripts in ways that we don't even learn about until 2 years later, which is very gratifying. But not all of our customers have this capability, and so in many cases we do the Lua scripting for them. But in the case of Kaiser, and especially Bruce, they do a lot of their own, which is why Bruce mentioned it on this slide. Go ahead, Bruce. Sorry for the interruption.
No, that's great. I use these products every day, and I forget to expand on the details of them. So this Lua scripting is great. It's a very powerful tool. There are times when, because it's a non-compiled scripting language, we decide that we want to move some of that logic externally into a web service, and we'll talk about that a little bit later, that does a lot of the heavy lifting. But in this case, the script will query our RIS and our PACS, sort of determine that study exists in these 5 destinations, and then appropriately route that study to those 5 destinations. So let's look at use case number 2 on the next slide, please. So not in every case is it as simple as routing a study. There are times when we need to change the data in the study. Often an outside study comes to us without KP identifiers, or it lacks standardized data in some tags like the study description. In the past, these studies would have been routed to a workstation or something like the Life Image Lila, which I'm sure we'll talk about here, that can act as a QC workstation and would allow a staff member to match that study to an existing patient and order before being ingested into the PACS. Over the last year or so, we've been using the 2 systems we're talking about today, along with some custom code we built in-house, to what we call auto-match these studies, and we're getting a really high percentage of those. I'll talk about it a little bit more, but about 80% of the studies we get in through this workflow are automatically matched. So let's see what that looks like on the next slide. So this diagram looks a lot like the previous one, but on this one, we're going to focus on the matching logic. The first part of the workflow is the same. The study is sent from an outside provider, and in this case, it's most likely one of our high volume outside providers that sends many studies to us each day. Those studies are again redirected to the unifier, and on that device, we pull the metadata from the study and we send it to a web service. That web service does the bulk of the auto matching logic. The web service will use data in our RIS in an attempt to match that study to an existing patient and order. If we can match it to an order with a high degree of certainty, we'll pass that match data back to the script that's running on the unifier. The unifier will then take the original metadata and store it in something called an original attribute sequence within the DICOM, so we have that forever. And then it'll update the study with the Kaiser accession number and the Kaiser patient ID and the way we spell that patient's name and all of those things. And it'll send it directly onto the PACS with no human interaction. So depending on the quality of the data from the sending site, we're seeing between a 70% to a 90% auto match for studies that travel through this workflow. And as you can imagine, this greatly reduces the work that our file room staff has to do.
So Bruce, that's a pretty staggering number when you think about how much time it typically takes to manually reconcile some of those incoming records. So can you share a little bit? I mean, it might be a little too detailed, but I think some of our audience members might want to know a little bit more about how you achieve that matching. What are some of the criteria that you're using? Is it, first name, last name, date of birth? What are the percentages of certainty that you're applying in the scripting to determine that you have a match?
Yeah, I don't want to get too deep into that, but you're right. We're looking at first name, last name, date of birth. We do a sound dex on the names in case it's spelled slightly different. We look for common name like Bob versus Robert. But that's still, because our population is very large, we have 4 million plus active members, that might not be enough in some cases. So if it's a workflow where we've specifically sent that patient out to an outside provider, we may quarantine those orders in a specific part of our RIS so the number of patients and orders that we have to match against would be smaller. And we rank that certainty level from 0 to 100, and we want to get it to 95 before we would allow it to match, where we believe that's as good or better than a person would do if they were looking at those studies.
Understood. Thank you.
Yeah. So as with all these automated workflows, there's going to be a certain percentage that can't be matched, either because we cannot uniquely identify the patient or they have multiple orders that could be possible matches. So those are routed to a QC workstation, in this case to Lila, where a staff member will look at all the possible orders, match them, and send them off to the archive.
Hey, Bruce, what kind of volume are you seeing? I know that percentage is large and really, great to see. What kind of volume does that represent?
These are great soft questions. I appreciate that. I expected this question, so I looked quickly. In the month of January, we imported approximately 14,000 studies into the Southern California region. And of those, 9,200 approximately were candidates for this logic. The rest are sort of one-off imports or providers that we haven't integrated into this logic yet. So and of those 9,200, again, we're matching about 70 to 90%.
That's excellent. Thank you.
Great. So in recent months, we've gone to the next level, which right now we're automatically matching against the existing orders, but there are cases where there is no order in our system. For example, a Kaiser patient receives care at a contracted non-Kaiser hospital. When that patient is discharged, we ask that facility to send all the studies that may have been performed during that stay. In this example, there's no order to match against. So what we're doing in a limited basis right now is if we have a high degree of certainty that we can uniquely identify that patient among all of our patient base, we will actually create an order in our RIS and then update the study with the metadata associated with that order / accession and send it into the VNA. Again, saving a lot of time for each of these imported studies. Let's go ahead and go on to the last use case on the next slide.
So Bruce, we will go through the Q&A a little bit later, but I think one of our audience members, Maureen Wong, has an interesting question that that could be really quickly answered here. Of the 70 to 90% of studies that are auto-matched, what percentage of these are international patients, if you know?
Zero.
Zero, okay.
Yeah.
Well, there you go, Maureen. That was a pretty binary answer for you.
Yeah, because the only reason they'd be sending them to us is if they were existing Kaiser members. Now, it is true that they might be receiving care at a facility overseas if they have an issue while they're on vacation. And that would be more of a one-off transmission that we don't run through this logic at this time. Okay.
Makes sense.
Okay. And right, I am not reading the questions right now, so thank you for bringing that up.
Yep.
So on this last use case, we've been talking mostly about sending studies to Kaiser, and we also have use cases where we're sending from Kaiser outbound. Historically and still today, often the sender at Kaiser needs to select from a list of destinations, but what we're trying to do is automate that whenever possible. Again, the idea is that automation is easier and fewer errors. So let's see what that looks like on the next slide. Within Kaiser Southern California, every study travels through the unifier. So this seemed like an ideal place to put business logic. One example that we're working on right now is that specific studies from a specific location may be routed to a Nighthawk service to be read. In the past, we would have expected the technologist from the modality to not only send to our VNA, but perhaps send to an alternate destination that would get routed to the Nighthawk service. Now, since those studies travel through the unifier, the scripting on the unifier can look at our RIS or other systems that know that this particular study should go to the Nighthawk service, and it can route to a specific AE title and port on the LISA, and we'll mention what that is here in a minute, which would then share it with the LifeImage cloud and to the outside service. And the LISA is one of several appliances from LifeImage that allow us to bidirectionally communicate with the cloud. Acts as a DICOM SCU or SCP, depending on how you're using it. In some cases, we go a few extra steps when we're sending traffic outbound. Again, the script on the router, unifier, calls a web service. That web service can identify priors that should also go to that destination and initiate those C moves. And then lastly, LifeImage does have a mechanism for combining results with uploaded studies, but we've chosen to build our own tools to pull that result from the RIS, convert it to both a secondary capture and a DICOM structured report, attach it to the study before it goes outbound. So these are just three simple examples. We view these products from Life Image and Dicom Systems as part of the tools on our tool belt. We combine them and other products, both off the shelf and developed in-house, to build unique solutions for each workflow. And we look forward to seeing how this partnership develops over time.
Hey, Bruce, this is Richie. Just a couple things really quick. First, just want to remind our audience, if you don't mind, if you could, prepare your questions and go to the Q&A part at the bottom of the screen to submit those, that would be great. And then Bruce, your last slide and use case, what kind of operational efficiencies have you seen by doing that? I mean, because obviously that's a game changer.
So the outbound right now is a relatively small volume. It's in the tens of studies per day. The vast majority of them, someone still says, I want to send this to hospital A, or I want to send this to hospital B. What we need to do is, so for this small subset, it's great because we don't accidentally forget to send it to the Nighthawk service and delay patient care. So for each individual study, it's great, but the volume is still not that great.
Got it. Thank you.
I think that's the end of my part.
Great. So let's recapitulate. We wanted to keep this presentation very focused on the freedom of interoperability that the partnership between our two companies are affording our customers, right? It's really clear that, either you're a customer of Dicom Systems, or you're a customer of Life Image, or you're a customer of both in the case of Kaiser, which means you don't need to buy any new technology from either one of us at Kaiser to do these kinds of things. And so the kind of network effect that is possible is what we'd like to underline here. You have an amazing, newly minted access to a large global network of academic medical centers, clinical sites all over the world. Dicom Systems has a presence in Europe, in Australia, and New Zealand. We even have some sites now in sub-Saharan Africa that are using our technology to bring telemedicine and teleradiology to extremely rural, underserved parts of Africa. So really, there's very little in terms of barriers to your ability to sharing data securely and fast over the cloud using our combined forces. And so we've had a couple of questions.
Hey, Florent, just real quick, just to add, I mean, because I think when you brought up at the beginning of the webinar about David's example for, kind of cellular compatibility and interoperability, I think what we're trying to demonstrate is that we actually are able to do that. I know the Life Image network certainly coexists and can broaden that spectrum, because we do make it easy to incorporate. And then by partnering with, Dicom Systems, we can kind of make those connections happen together, and we can promote better sharing and exchange overall. So I'm glad that you guys were able to participate in this, and we'll kind of turn it over to the questions now.
Yeah, I think one more interesting point to that end is that we're hoping to spearhead a movement, not just provide interoperability between two imaging vendors. That's important, but it's a start.
Yep.
What needs to happen now is that we're hoping to show an example to other enterprise imaging vendors that being open and interoperable is actually good for everybody, especially patients and caregivers. And so
I can't agree more.
What we're doing in the best interest of our own enterprises, Dicom Systems and Life Image, is in fact going to be to our benefit as companies, right? Because we're going to enable more and more interoperability in the marketplace, and we would encourage companies that are perceived to compete with us. The Nuances of the world, the Ambra Healths of the world. There's a lot of companies out there that are selling image sharing and enterprise imaging technology. And so we would like to encourage them through this webinar and future webinars that we're going to hold together to join us and make this easier for everybody. And by not requiring, every vendor to sell their platform in order to be interoperable. There's a lot we can do in this, and we intend to advance interoperability more and more.
Well put.
So Richie, I believe there was a question that came through that would be best answered by Life Image. You know which one I'm referring to?
Yeah, I believe Maureen submitted a question. I'll ask the question, and this is Maureen Wong. Does Kaiser allow sending facilities to connect to just one destination on their side? Bruce, or is this in the plan? Bruce, you can answer that part, and then I can talk about the rest of the question.
So our connection philosophy is changing over time. It's true that we could have everyone sent to a single box, but what we may do is that everyone within, say, UCSF sends to their own box, which is separate maybe from the studies we get from UC San Diego. Therefore, we have some idea of where it's coming from, because you're correct on the second part of your question, which I'll let others speak to.
Yeah, and also, you know, just to kind of, I know that it was noted that there's a limitation on the cloud because it doesn't easily allow for single destination. Well, that is pretty much fixed when you have a permanent sender, a sender that sends you frequently. That's where you kind of you solve it with the component of light, because there's a direct connection and there's no need for any forms. There's a next question by Mr. Jackson. Are all matches manually associated by clerical personnel? And is there a process to auto match? So Bruce, that sounds like it's mostly directed to you.
Yes, and I know Mr. Jackson well. I think we mentioned that earlier. The idea is that more and more of our inbound studies are candidates for auto matching, and for those ones that are candidates, we're hitting a really high percentage. It involves some legwork up front where we look at the information coming in, maybe get a crosswalk between their exam descriptions and our exam description so we have a better hit rate. But we are being very successful in matching with some of our large senders, and we get hundreds per day that are auto-matched.
Great. There's just a quick comment. Somebody did ask that they had purchased Life Image already, but they would also love to see how they can also get Dicom Systems, and we can actually reach out to you to help you with that. We would love to have that discussion. So we'll definitely note that and follow up.
Yes, Hamza, if you would, you know, share your email address with us in, you know, a private chat, we'll gladly contact you and talk about possibilities.
Another question from Mr. Jackson. Is there a need for both Hospital A and Hospital B to leverage LI and Dicom system platforms? It depends on how you want to perform your data flows and your workflows. Typically, if you're wanting to exchange, you definitely will need an exchange platform. And if you want to do intrinsic workflows that may need to be automated, you definitely would need to use Dicom Systems. I'll let Florent add, or Bruce add anything else that they would think of about that question.
Yeah, so the best way to answer that, Akwasi, is very simple. No, there's no absolute requirement for for the second hospital to have the Dicom Systems platform. If you're already leveraging Life Image, the cloud platform is what's going to enable you to complete that transaction over the cloud. What Dicom Systems allows you to do is more of the automation of this process, right? The ability to set some automated rules to handle certain types of images to send through the cloud, or receiving them from the cloud and pushing them to PACS or VNA. So the enhancements that you get by using the partnered platforms is in the result in more automation.
So this is Bruce. Let me add to that. I agree with what was said. You know, how you get things into the Life Image cloud doesn't need to be the same on both sides. But right now, the different cloud providers do not communicate with one another. We mentioned that early on. Someone used a cell phone analogy. I use an email analogy. The fact that I might have an Earthlink account, you might have a Google account, I can get to you with no problem. That's not where we are today. We all know the alphabet soup of standards, both real and proposed, for sharing images on the internet. I believe what we're doing here today is setting the groundwork for integrating to those standards so that different hospitals that are working with different vendors can still exchange images.
Yeah, and just to add to that a little bit, Bruce, and thank you for stating that. At Life Image, we have already undergone a transformation to allow that to happen. And we actually have a use case that's being stood up today that allows for that to function. Looks like, Todd, you had a question. Does Life Image operate multiple hubs in different regions, countries due to PHI regulations? Yes, we can, meaning that we allow connections because many of our customers receive referrals from other countries, and they have medical vacations to come to the US. So we do allow for that digital transfer across the cloud, across the globe. And that's how the components can be dispersed. It can be ad hoc, it can be light. There's a lot of different ways that you can do that. And that's what we've kind of extrapolated to make sure that our customers that do need that and then are serving other countries are able to do just that.
So we have another question that I think is very important and is likely for Bruce, and that is from Arthur. How are trauma transfer images handled if patients are not registered at your facility? What is the workflow for these patients' exams to automatically send to PACS?
So good question. That may not always apply to the Kaiser Permanente model. While obviously our ER will serve patients that aren't members, anyone that's being transferred to us, the only reason they would be transferred to us is if they were a member, and therefore they're already registered in all of our systems. So that doesn't apply. In the unlikely situation we get a study in that can't be matched to a person, then we'll have to create a temporary record in our EMR, which then percolates down to all the other applications.
Great, thank you, Bruce. That means we have no other open question. Oh, we have one more question from Maureen Wong. How is Kaiser Permanente getting the order to that the router is auto matching on? Is the HL7 order entry feature from Life Image being used?
So this is our inbound traffic, and the orders are placed in our EMR. They're sent to our RIS. So those orders are sitting in our RIS, and assuming we get that study back for an order that we've already placed, we sent that patient out to be scanned. We query our RIS on a number of criteria to try to uniquely identify that order and match it with that image. So the Lua script, which can do a lot of things, but we tend to keep it more compact, calls a web service, which does all the querying to the database in our RIS to find that information.
Great. I think this may actually complete the questions. Well, Maureen has a lot of follow-up questions. We appreciate that. Also, the unspecified filter in PACS, is that an image library function to clean up and match patients with orders?
So I'm not sure what unspecified filter in PACS is. Sorry.
So I imagine.
So Bruce, this is my perception of it, and maybe Maureen could type in a little bit more, just in case. But when you have the unspecified list, if you will, inside the PACS system, meaning that it's not matched to any kind of order whatsoever.
Yeah, so again, we try to match it. If we match it, we put the fact that we match it into a private tag, and that forces it to be routed directly to our PACS. And if we could not match it, we put basically the word no match into that private tag, which then causes a routing rule to send it off to a QC workstation. And in this case, we're using the Lila for that.
Great. Thank you, Bruce, for clarifying. Appreciate it. So that will conclude the questions. If there are additional questions, please submit them and we can follow up off of line. But we also wanted to point out that for those of you going to HIMSS, that we will be at HIMSS from February 11th to the 15th, coming up in Orlando. Both on the screen, you can see where both booths are located. Life Image is at booth 1615 and Dicom Systems is at booth 5349. I personally, this is Richie, would love to thank all of you for attending and especially asking questions. And Bruce, I can't thank you enough for participating in and conveying the real life use cases that are used in your institution to show the two technologies. And last but not least, Florent and the Dicom Systems team, it's been a complete pleasure working with you and bringing this partnership to life.
Thank you so much, everybody. We do have one more question from Lisa Duncan, and we will answer it separately from this meeting. I believe we're about to end, or do we still have time to answer this question? I think we do, right? We still have 5 minutes in the hour. So let's do that. Lisa Duncan, are there any plans to implement an electronic request for images with Life Image Cloud connections? Also, a message center would be helpful when communicating with connections. So that's for you, Richie.
Apologize, I'm not seeing the question. I think it would probably be better so that I can read it thoroughly and give an appropriate answer to just answer offline.
Okay, I can read it again for you. It's really quick.
Okay, go for it.
Are there any plans to implement an electronic request for images with Life Image Cloud connections? Also, a message center would be helpful when communicating with connections.
Yeah, so we're doing these modifications to cloud all the time. And we've had this come up before, Lisa, and how we kind of collaborate that. Because we've worked on a lot of automation, both within cloud, Lila, and Light, especially together, we're trying to cut down on the need to require manual interaction. But I definitely want to take this information and follow up with you and get a little more granular on what would make sense, because that will help us kind of go in the right direction and get some more feedback, because obviously we always love hearing from our customers and how we can improve this particular piece.
Very good. Well, I think it's time to part ways. Really appreciate everyone joining us today. This was a very invigorating conversation. Anytime we talk about, where is image sharing going next, it is far from being a dry subject, and really hope to see all of you at the HIMSS conference. Feel free to stop by. We'll have an espresso machine in our booth, and we'll be happy to have a conversation with you there. Thank you so much, everybody, and we will end the webinar now.